Hello, my name is Dr. Ros Taylor and I'm a palliative physician. So I help to improve the quality of life of people with advancing illness, often cancer. And I have a lot of experience working with people with NET tumours, neuroendocrine tumours, and particularly those with difficult symptoms such as pain. So today I'm going to talk about pain in its very holistic sense. And I wanted to start with this quote, which I love. You can't find inner peace in that darkness of pain. The pain blinds you to all that's positive. And I guess what that means for me is that if pain isn't addressed properly, then it's really difficult to make the most of your life, however long you have to live, whether it's years, months, or hours. So I'm very aware that some of you watching this will actually have family members, or you yourself will be going through a journey with a neuroendocrine tumour. So I hope that nothing that I say upsets you. I'm going to try and give you my perspective on pain, what it means, and the various treatment options and some of the myths. So my view is that all symptoms are total symptoms, and I'll explain what I mean by that. All symptoms have a physical cause, like the cancer pressing on something, but there's also an emotional, a psychological, a social, perhaps a financial, a spiritual overlay that will affect how pain is perceived. So if I've got a bad headache, I can take some paracetamol, that might help the pain, but I could distract myself by watching a good Netflix film and I won't feel the headache so much. So there's so many ways we can modulate pain that don't just rely on medicines. Pain, in my experience, is one of the most feared symptoms of advancing illness. But I guess I want to start by saying pain is not inevitable in all cancers, and it's not uncontrollable. There's always more options to try to help you reduce your pain, live with your pain, manage your pain. And for me, this is another key quote. The pain is what the patient says it is. Your doctor, your nurse, the family can't see your pain. They can only see how it affects you. So we have to take pain at face value and analyze it in order to help you. Pain is what hurts. That picture is full of pain, isn't it? So if we're talking about NET tumours or any tumours, there are many causes of pain. It could be the cancer itself, pressing on organs, pressing on nerves, pressing on bones. It could be the treatment. I've got a lady at the moment whose worst pain is her mouth ulcers, which are due to her chemotherapy. The mouth pain is getting better, but it's the treatment causing the pain, not the cancer. General weakness makes everything more painful. Chemistry. So in particular with neuroendocrine tumours, a lot of chemicals can be released by the tumour. Hormones, calcium, thyroid hormones, lots of chemicals can upset the balance of pain. And of course, you may have another illness like rheumatoid arthritis or a bad back from other causes. So not every pain is due to cancer, but often when you have cancer, every pain is put down to the cancer, and that's another key message to consider. So I'm not going to talk much about the physiology, the biological basis of pain, but just to remember that all pain has to be transmitted by nerves, and these nerves go to the spinal cord, and then they travel up the spinal cord to your brain, which is where you sense the pain and feel the pain. And most of the treatments to help pain are about interrupting this complex nervous journey. So we'll talk a bit more about that later. And my last two biology slides, just to describe the two different pains that doctors often think about. There's nociceptive pain, that's a tricky word for me as well, which is about organ-related pain, pain from swollen liver, or pain from lining of the lung being involved. It's all about tissue damage. Whereas there's also neuropathic pain, and I'm sure some of you will have heard of this, which is where nerves are directly involved by the cancer, either being pressed on or invaded. And nerve pain can feel slightly different. We often hear descriptions like stabbing, stinging, burning, and often the skin in the area of pain might feel numb or perhaps oversensitive, and that gives a clue that this is a nerve pain. But the key message for that, and from what I've learned over the last many years that I've been working in palliative care, is that whatever the cause of the pain, that doesn't always help us find the best remedy. So medicines that work for neuropathic pain also work for other pains, and the other way around. So don't be too blinkered by some of these definitions. So pain is obviously treated by analgesics, pain medicines, but in so many other ways as well. And I suppose a key message for those of you watching today is that pain is also experienced by those close to the patient, close to you. The whole family can feel that pain or suffering. So back to that concept of total pain. I've already said that the amount of pain felt is affected by your mood, by external factors, and perhaps most importantly, by the meaning of the pain. And I'll talk a bit more about that. So let's meet John. John is 46 years old and he has a NET tumour in his chest. That's where it started. He's married to Annie and they have 2 kids, aged 12 and 9. He's lost a lot of weight recently. He's becoming weaker. He has a lot of pain and he is struggling to keep going to work, although he wants to keep up the family finances. So there are many, many reasons for John's pain. And when I meet John, I will be looking at 4 things. I'll be looking at what's physically causing the pain. What does the pain mean to John? What's the impact of the pain on John's life? And what can we do to help? So it's not just about a prescription. This is about a conversation. And I hope that some of you who are in touch with oncologists or palliative care teams are able to have this much broader conversation about your pain. So to John, his pain means his cancer treatment isn't working, or he's wondering if it's working. Is the cancer spreading? The pain is getting worse. I'm going to die. So these are the thoughts that increasing pain mean to John. More thoughts. He feels he's got a strong faith. What have I done to deserve this? I'm being punished with this pain. God has deserted me. So really unraveling the meaning of the pain, what do you think this pain means, can really help explore some of the psychological dynamics and spiritual dynamics, and sometimes just exploring those will help reduce the pain. So moving on to the impact of the pain on John, I mean, I guess it's pretty obvious. He's becoming depressed with the pain because his life is altering. He's doing less at home. He's struggling with stairs. He's struggling with sleep. He's getting isolated from his friends because he hasn't got the energy to go to the pub or to play golf. And his relationships with his family and his children, he's becoming disengaged. So this is massive, and massive. It's more than the pain. So it's all about losses. He's losing his role as a husband and as a provider. He's losing the control that he had in his life, and perhaps he's even losing his purpose. So I've seen many times that uncontrolled pain can lead to people's wish for death to come sooner. So that's why it's so important to look holistically, not just get out a prescription pad. So that's what I mean by total pain. It's the total sum of the suffering, a feeling that there's no end, a feeling of hopelessness. And there are so many ways we can help with this level of despair. This is an amazing drawing. It was done many years ago by a younger patient I looked after who had a neuroendocrine tumour. He did this with a black felt pen when he was in the hospice on a piece of flip chart paper. And I've used this picture many times. And I've talked to nurses and doctors and patients and families about what this picture means to them. To the patient, this meant that he was being supported. And sometimes that support was his family, his doctors, his nurses, the hospice nurse, his art. He was an artist. You can see that he's an artist. Some people actually see that he's being squeezed rather than held. But sometimes just using art or poetry or literature can help you get in touch with what's really causing the suffering. So that's something that's often really helpful when you're trying to explore pain. So, total pain. Really need to analyze the psychological, the spiritual, the physical, and the social. And I think I've gone through all of this. And all of these pink boxes have had an effect on John's life. So there are many things that we can actually intervene with. So moving on to the treatment of pain, I guess the first question is to find out what the patient is expecting. For many, it's just to get a peaceful night without pain, or just pain at rest so that you can watch Netflix. For others, it'll be, I need to have less pain when I move about, but set an achievable goal. It may not be possible to reduce the pain so that somebody can go skiing again. So it is about realism and agreeing small steps that you can be successful with. And then, as I've said before, to look at all of the dynamics that are affecting pain. And we have many tools in our pain toolbox. We have conversation, and I think conversation is one of the most important. We can obviously modify the cancer, we can offer radiotherapy, we can cut the cancer out, we can try different medications. There are also many non-medication methods, and I'll mention those briefly. And we can actually block some of those nerve pathways. That's pretty specialist stuff, and I would hope that most of the ordinary methods to help pain are the things that we need to try first. And finally, it may well be about modifying the way of life. I have many conversations about perhaps moving a bedroom downstairs. That is massive for people. So if there's any way that we can still manage stairs, it might be about hiring a stair lift, or it might be about seeing a physiotherapist who can help you manage the stairs with less pain. So modifying life, working from home, and that's, during the COVID pandemic, many people can work from home rather than travel if driving is difficult. Modifying our way of life will help to modify the pain. So I've talked about treating the cancer. Many of you will be familiar, and cancer treatment is advancing all the time. And for NET tumours in particular, there are so many innovations coming along to try and shrink tumours and stabilise tumours. And if we shrink a tumour, it's likely that the pain will reduce. How can we interrupt the transmission of pain down those nerves that I mentioned? Well, I guess our main tool is analgesics. There are nerve blocks, pretty specialist, and of course there are ancient remedies like acupuncture, and many patients get relief from acupuncture if you can get access. So let's talk a bit about analgesia, as there are many myths. Really, we should take medicines by mouth if we can. Excuse those pictures of lips. Patches are also fine, but we want to keep away from injections because they're complicated. And what I mean by the clock is if you have pain all the time, then it's best to take long-acting medication that will give you a continuous pain relief rather than just keep taking short-acting medicines that last for a few hours, give you some pain relief, but then the pain relief drops off and then you have to take more. So long-acting preparations are good, that's by the clock, but you might still need a top-up dose if you're going to do something that is going to make your pain worse. And review regularly if those medicines aren't working. So before I talk a bit more about analgesics, we always need to think about these other measures. My sister has just had a big operation on her knee, and she finds that ice packs are more helpful than any of the tablets that she's been prescribed. Massage is amazing if you can get access. We naturally rub painful areas if we hurt ourselves. If you bump into the side of the bed, your natural instinct is to rub it. Massage can fool the brain and block those pain messages. And I've already mentioned practical measures. So if you have, for instance, cancer in your spine, every time you walk, all of that pain will be going up through your spinal column. If you use a walking stick or a frame, you are taking away some of that weight bearing through your spinal column and the pain will be better. And some of these additions like walking sticks and frames are really difficult for people to be introduced to people because they mean something. A Zimmer frame means my cancer is getting worse. It's not just about the occupational therapist applying one. It has got meaning and we need to understand that. And all of the other non-analgesic measures, creative writing can help manage your pain, breathing, yoga, exercise, just anything that helps your brain release your natural endorphins, those chemicals that our brain can produce that will suppress your pain. Music therapy. Now, I know that not all of you will have access to some of these therapies. If you live near a hospice, then many hospices have these sorts of services that may be available to you to help you manage your pain. So think creatively about what's available locally, other voluntary groups, because all of these options will help to reduce your pain. And now I just want to spend a few minutes thinking about the conversations that I've already mentioned about how to explore pain. When I meet somebody in pain with an advancing tumour, a NET tumour or any tumour, I ask this question: what really matters to you if time is short? And many people are aware of their prognosis, whether it's months, hours, days, weeks. And most people will answer that spending more time with their family and friends is all that matters. But some people have bigger goals. Some people want to remain at work for as long as possible. Some people want to go and climb a mountain, not many. But knowing what matters will help to decide how best to help the pain. And it's a really important question. And it opens up a conversation that will help to develop rapport, engagement, and get to the right therapy for the pain. I do something called a whole life grid with people. It only takes about 2 minutes to find out what life was like before the cancer or before the pain and fill in the boxes. So John enjoyed spending time with his family, going to work, loved the pub, loved doing some gardening, loved his family holidays. Unfortunately, he supported Manchester United, and he liked going to the cinema. So my work with John would be to say, okay, which one of these boxes that you've lost can we now reclaim? How can we get you to the football match? He's got a season ticket. Might it mean a wheelchair if walking is too painful? And then a conversation about what a wheelchair means. And of course, nobody knows that you're not in a wheelchair because you've had a skiing accident or fallen off your bike, but wheelchairs still are very difficult for people to adjust to. But maybe getting to the football match would lift his spirit. Can we get you back into the garden? Can we garden in a different way? So a whole life grid, and you can help your doctor and nurses by suggesting which bit of your life you have lost and you want to reclaim. Sadly, my whole life grid would be work, 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 sleep. But most people have more interesting lives. And I think that this is such a simple exercise that paints a picture of life, which will help to focus on the management of your pain. So we've asked what matters to you. It's also really important for your healthcare team to know who matters to you and how they can help with your pain control. So what matters to you and who matters to you. So back to John, what did we do? His pain has been helped, thankfully, by chemotherapy and some radiotherapy to his chest. And he's on a pretty complex regime of painkillers now, which is allowing him to sleep at night, to drive again, to do some part-time work, and actually do a bit of clearing in his autumn garden. Not too much, he's pacing himself. He's also on an antidepressant, and he has been seeing a counsellor to explore some of the anger he has about his cancer, about family relationships, about why his sister has stopped phoning him since he developed cancer, etc. And then there's the practical solutions. So one of his work colleagues is picking him up on the days that he doesn't feel able to drive. Just very simple, practical options to help life be as normal as possible. And he has spoken to his priest about his fears of his own death and what happens after he dies and what might happen to his family. He's still got a really good prognosis of many months, possibly years. And I'm pleased to say that with all of these interventions, his pain is much better. So as I'm drawing to an end of this talk, I just wanted to mention a few myths. There are many painkillers. There are opioids like morphine and fentanyl and oxycodone. There are anti-inflammatories like ibuprofen and diclofenac and naproxen. And there are nerve-killing agents like gabapentin and pregabalin. And we often use a mixture of different painkillers because it's very rare to find one painkiller that works. But we do like morphine. And here you can see the beautiful purple Papaver somniferum, the opium poppy. And there are a lot of myths about morphine. It is the oldest painkiller, the painkiller that we best understand. But of course, there are concerns about addiction. If you use morphine in appropriate doses for pain relief, you will not get addicted. You may get tolerant, which is different, which means that you may need a slight increase of dose to get the same result after many weeks or months, but that's not addiction. If the pain goes, you will be able to stop your morphine. Morphine often leads to the question, am I dying? No, We use morphine a lot for people in the middle of treatment or after surgery, or if you break a bone. Morphine does not mean you're dying. And there are many ways of giving it, in liquid, in long-acting tablets. And will it carry on working if my pain gets worse? Yes, is the answer to that. There is no upper limit to the dose. So I want you to be less fearful of morphine and to trust your doctors to use it safely, and perhaps your nurses to use it safely in appropriate doses, or to use an alternative if morphine doesn't suit you. But it is our trusted favorite analgesic for severe cancer pain, so don't be too nervous. So I look upon pain, whether it's a NET tumor pain or another pain, as an apple pie. And we have to use all of our different tools in the toolbox to help. I hope there aren't too many patients looking like our man on the right, but we do see an awful lot of polypharmacy where people are on 10 medicines or more. So John is on a mixture of morphine and ibuprofen. He's having some acupuncture and he's also going to some yoga classes. There is still a small section of his pain, a proportion of his pain that we can't control. And that's maybe going to be helped by counseling or by his priest. And those are my 2 question marks at the top. Lastly, I get loads of questions about cannabis and CBD oil. I think these will have a role in the future, and more research is being done all the time. Medical cannabis is now legal in the UK, but it's incredibly difficult to get hold of. It's mainly available privately, but I think we will see a change over the next few years. It is used widely in other countries, and I think England has always had a very restricted approach to cannabis, but I think we'll see some developments, I hope, because I think it really, really will have a role to help with complex pain. So I haven't talked specifically about neuroendocrine tumour pain because the approach to pain, whatever the tumour, whether it's a NET tumour or a lung tumour or a pancreatic tumour, is the same. It's my holistic approach to total pain, and I hope that I've given you some ideas to think about. NET tumours can occur, as many of you will know, in many different parts of the body, so they will cause different sorts of pain, which will need different approaches. I'm also seeing in some of the patients I'm involved with NET tumours that they can get really, really severe surges of pain. And I think this is quite mysterious, and I think it has not been researched enough, but these might be hormone surges released by the NET tumour. And I'm working with some oncologists now to think about research to understand what these pain flares might be, because they can be very debilitating. So I have shared with you my approach to pain. I hope that many of you who are watching this here will have some additional ideas now in your toolbox to approach. And if you want to read one book that will help you in your management of your illness and the questions you need to talk to your doctors and nurses about, this is one of my favorite books. This is written for the public by an Indian American surgeon, Atul Gawande. He's very well known, but this is an amazing book, Being Mortal. I recommend it to every doctor and nurse and patient that I see. So thank you for listening, and good luck with your pain and with your life. Thank you.